Test, test, test. So my daughter at Greenville, her two roommates are both softball players, and they have, let's see, she's been quarantined twice. They've been quarantined once. Good morning, Jesse.
Morning.
And she's never tested positive.
Yeah, that's not like my roommate tested positive in the fall, and I didn't test positive.
Yeah,
And then it tested positive this time.
yeah. Her, Emily's boyfriend tested positive and actually was pretty sick. His whole family got sick over Thanksgiving. And this kid, you know, he's a baseball player. He's in good shape. He couldn't breathe. No, he wasn't hospitalized, but he was pretty sick. So, I mean, that's enough to put the fear of God in you, I think.
I think it wakes a lot of people up.
Yeah. She has a acquaintance who runs cross country who had COVID-19. She can't climb stairs now. She's so wiped out. She's a so-called long hauler. And it's sad. It's really sad. You see a vigorous 19-year-old taking the elevator because he gets so tired climbing stairs. Someone who used to run half marathons now can't even climb stairs. It's these people who say the virus is survivable, don't wear a mask, masks are political, and want to just reach through the computer and just strangle them. And then former students of mine who take care of COVID patients, people your age, who look them in the eye and can't breathe. It just, yeah, it's just. I'm talking to your colleague, Jesse, here. Kelsey's right here. Kelsey sits in front very dutifully. I think Coach Thompson tells you guys to do that, right?
Yeah, she says first 3 reps.
Yeah. Yep, that's sweetie. She's probably one of my oldest friends on campus. Easily. I've known Deb for a long time. Testing. Testing. Hey, Hope. You feeling under the weather, Hope?
Yeah, I traveled for the Super Bowl, so I just stayed back instead of trying
You
to.
didn't go to Tampa, did you?
No.
I was gonna say, you lucky girl. Okay, well, get started here. Okay, folks on Zoom. Do the slides move? They are? Okay. All right, do the slides move? They do? Okay. Good morning. It is good to see some of you back from quarantine, Kelsey. And we have some of our folks on. Nana, can you kill these lights here again? The glare. Man, that glare is bad. How many of you stayed up late and watched Super Bowl? 43 years old, still winning Super Bowls. You gotta hand it to the guy. Love him or hate him, you just gotta hand it to him. Having said that, I do not endorse some of Tom Brady's wacky ideas about health. If you read some of the stuff that he said about, yeah, some of his ideas are really strange. Anyway, but he works very hard and he deserves a lot of credit. Okay, we are on the tail end of pharmacodynamics. Then we'll get into pharmacokinetics. And from there, we'll go into how drugs are metabolized by the liver. And we'll look at pharmacokinetic drug interactions. We'll talk a bit about pharmacodynamic drug interactions today before we sign off pharmacodynamics. And after that, we will get into the circulatory system and drugs that affect the circulatory system. Let's have a word of prayer and then we'll begin. Lord, it's cold out there, so please help us to bundle up, wear our booties, be smart by not staying outside quite too long, and covering places so that they don't get frostbitten. Thank you for every student here. Thank you for those who are back with us from quarantine. For those who are now on to quarantine, please continue to watch over them and help us, Lord, to live smartly. And we pray that this vaccine gets out quickly before these variants of concern overtake us. In Jesus' name, amen. Now, we finished up last time talking about potency versus efficacy. Potency versus efficacy. Potency is simply defined as the concentration at which you achieve EC50. EC50 meaning the effective dose 50. The dose at which you get 50% of the full physiological effect from that drug. That physiological effect could be anything. Lowering blood pressure, heart rate goes down, animal becomes sedated, whatever. So you have some sort of objective measurement of the physiological output of the animal. You're able to measure the physiological effect of the drug. You have some assay, whatever it is, you get half that effect at a particular dose. If you achieve, you being the drug, achieve that EC50 at a certain dose, that's your potency. The lower the dose at which you achieve EC50 is the higher your potency. Potency says nothing about the maximum effect of the drug. Nothing. Efficacy has to do with the maximum effect of the drug. It says nothing about the dose at which you achieve it. It has to do with the effect, the maximum effect of the drug. So with this slide here, you could see B is more potent than either C or D. However, D is more efficacious than B. So with a drug, you want to maximize potency and you want to maximize efficacy. That's your goal. You want a drug that is both potent and efficacious. That's the goal you're shooting for. So drugs A and C and D all have maximum efficacy, but A is the most potent. So A is your best candidate. And if you get a dose relationship curve like this with D, it's probably too toxic. So for example, if this drug, say, was a sedative hypnotic, a drug like that would probably cause you to fall into a coma rather easily. So a drug whose response curve is this steep is probably too toxic. So shape of the curve is also important. This is a quantal dose effect curve. You do this in laboratory animals. With this test, you feed the drug to the animals, you get the ED50, effective dose 50, the dose at which you get half the desired effect, and you keep feeding it to animals at higher and higher doses. And then you start to get toxicities. So the dose at which you get half the animals showing toxicity, or the dose at which half your animals die, is called either the lethal dose 50, LD 50, or if you have one of these drugs that really rarely kills the laboratory animals, then it might be called the toxic dose 50, the dose at which half the laboratory animals experience toxicities. So it's very hard to kill a laboratory animal with fexofenadine. Very hard to kill a laboratory animal with loratadine. So with drugs like that, you will report a toxic dose 50, not an LD 50. With heart medicines, it's another story. You can't kill your laboratory animals. With those, you will report an LD 50. Then you will report to the FDA the ratio of the LD 50 to the ED 50, or the ratio of the TD 50 to the ED 50. That ratio is called the therapeutic index. The therapeutic index. You want the therapeutic index to be as big as possible. A big therapeutic index is good. A low one is not so good. So let me give you an example of one particular drug. It's used quite a bit, actually. And let's take a look at its therapeutic index. So here is digoxin. Digoxin is a drug we will talk about. It is given to patients with heart failure. It helps the heart beat more forcefully. Here is the dose, 0.8 to 2.0 nanograms per ml. Here's the toxic level, anything above 2.4 nanograms per ml. You think you could calculate therapeutic index from those two numbers? I'll bet you could. You divide this number by this number, and that gives you a therapeutic index, and it's going to be just over 1. It's not going to be very high. And digoxin is a particular drug whose therapeutic index is low. And dosing digoxin is very difficult to do. It's a nasty drug. It also interacts with everything under the sun, practically. So, well, let's just pull out our calculator here. Okay, so 2.4, oops, decimal point didn't quite work there. 2 point, there we go, 4. We're going to divide that by the maximum dose, 2.0. There's your therapeutic index for that drug, 1.2. That is not a very good therapeutic index. That's terrible. So that shows you essentially how to calculate a therapeutic index. Now, in your notes, you have some tables that give you target concentrations and toxic concentrations here, you should be able, from these numbers, to calculate therapeutic indices for these drugs, couldn't you? Given what was just told to you. So that might be an exercise you could do to help you familiarize yourself with this concept of therapeutic index. This is a very important exercise when it comes to developing drugs and then reporting them to the FDA and so on and so forth. Very good. Any questions about any or all of that before we move onward? Effective concentration 50, that's concentration in the tissue. So if you do an animal necropsy, and say you take a liver sample and you get the concentration of the drug or its effective metabolite while the drug was working, or you take a blood sample and you get the concentration of the drug in the blood, that's effective concentration. ED is effective dose. That's the dose you give the animal to achieve that concentration. Usually, when you're reporting to the FDA, you report both numbers. If you don't, the FDA will ask you, why don't you have both numbers here? If you say, well, we didn't do the necropsies, the FDA will say, okay, go back to the lab and do them, then report to us later. For therapeutic index, typically it's reported as effective dose. Sure. That better? Yeah, okay. Now, how are we going to get pharmacodynamic drug interactions? This will occur if the mechanism of two drugs overlap. To illustrate this, let me use something that comes up really commonly in medicine, particularly with elderly patients. Have any of you heard of a drug called donepezil? I think the trade name of this drug is Aricept. Aricept. Any of you have grandparents, or maybe parents in your case, who are experiencing some dementia? Sometimes the physician will prescribe a drug like this to increase their short-term memory and to prevent those little episodes that people with dementia sometimes have where they don't know where they are. No one's heard of this drug? No. So this drug is a acetylcholinesterase inhibitor. Oh, acetylcholinesterase inhibitor. Boy, that really excites me. What the heck does that mean? Well, acetylcholine what's that? Thank you. Neurotransmitter. In the brain, acetylcholine is an important player in learning and memory. So if you prevent its breakdown, what happens to learning and memory? It tends to go up. Now, acetylcholine binds to receptors in the brain called muscarinic receptors. And it binds to so-called M1 and M2 receptors in the forebrain. and these play an important role in learning and memory. So let's say grandma, oh, let's give her a name. Kelsey, what should we name our grandmother? Betty. Let's say Grandma Betty, she's getting a little forgetful, and you asked her to come, and let's say you got married. Let's say you have 2 kids. Okay, 2 kids, and Mom, can you come and watch my boy and my girl? Okay, 2 girls. My girls. Good. Yeah, girls. Okay, girls. Nuclear family, sure. Okay, so Betty, she just lives one street over, but she takes a little longer to get there. She finally gets there. She says, Mom, what happened? Did you do something before you left? She said, oh, I just decided to take a little extra walk. Translation, she got lost on the way to your house. That's a little scary. A little scary. So she goes to the doctor, and the doctor says, well, we can give you this low dose donepezil, and before long, she never gets lost going to your house anymore. Well, 7% of people on donepezil get urinary incontinence. That's embarrassing, wetting yourself and stuff like that. So she goes to the clinic on Main Street, the walk-in clinic. Does she tell the doctor that she's on donepezil? No, she didn't remember. So what does the doctor prescribe for her? The doctor prescribes oxybutynin, very commonly prescribed drug for urinary incontinence. Why does the doctor prescribe that? It works, and it's cheap. It's really cheap. And Betty, she's on Medicare. So you pick the cheapest drug. Because if you get a more expensive drug, Medicare may not pay for it. Now, here's the thing about oxybutynin. It's very lipid soluble, so it crosses the blood-brain barrier. This thing inhibits and antagonizes muscarinic receptors. And in the detrusor muscle of the bladder, you have M3 receptors. Well, oxybutynin blocks this receptor really well, but it also gets into the brain and it blocks this receptor and this one too. So now you call her up saying, can you watch my girls? And then you get a call a couple blocks over, and he said, you know, we found this lady wandering in our backyard, and she didn't know where she was. And I just brought her in. She was freezing, poor dear. And I saw your phone, and her phone was your number. And you're like, oh my goodness. And you take her to the doctor, and the doctor doesn't know that she's on this. And the guy who prescribed, or the gal who prescribed this, didn't know she was on this. You see, it's a pharmacodynamic drug interaction. This happens a lot more often than you think it does. This is the reason why, if you're an OT, if you're a PT, before you can do a single thing to that person, you must know every drug they're on, and that includes herbs. Because some herbs interact with drugs. There's a herbal remedy called St. John's wort. Have you heard of it? The number of drugs St. John's wort interacts with goes from the top of that wall down to the wall on towards the back wall. It's huge, absolutely huge. Interactions with St. John's wort has caused deaths because people haven't told their doctors or nurses or whatever that they're on it. So get all the drugs patient is on. It's vital. You may save their life. You may save their life. And if they bring in a big bag of stuff and tip it over, this actually has happened to friends of mine. You may see stuff in there for their dog that they take. Why? Guess what gets prescribed to dogs? Ketamine. You take ketamine, you're feeling pretty good, right? Got that awful arthritis. It won't go away. Take some ketamine. And guess what? Ketamine is cheap. It's really cheap. So you'd be surprised. Well, don't be surprised. Nowadays, what people are taking, just make sure you get everything. Just say, look, just throw it in a bag, bring it to me, and dump it on the table, and I'll deal with it. So anyway, that's a little cautionary tale about drug interactions. Yeah, Josh.
If
Oxybutynate.
if it blocks those receptors, wouldn't it stop learning anyway, even if it's not, even if you don't have?
Usually, if you're younger, it's not a big deal because your metabolism is such, you get washed out of your body. Well, also, as you get older, your sensitivity to perturbation of these receptors goes up. So your pharmacodynamic, that's one pharmacodynamic pathway that actually gets more sensitive. That's why anticholinergics, that's what this type of drug is called. In elderly people, if you use them, you have to use them with tremendous caution because they can cause dementia episodes, even in healthy elderly people. Now, the way you get around this is there are agents that don't cross the blood-brain barrier, like trospium. Trospium is a quaternary amine, doesn't cross the blood-brain barrier, or solifenacin, which goes by the name, don't tell me, Vesicare. Vesicare is an M3 specific drug. So even if it crossed the blood-brain barrier, it's not going to bind those other two receptors. Also, darvacenavin also doesn't cross the blood-brain barrier, but those drugs are more expensive. Do Medicare pay for them? If you're somebody on a walk-in clinic, you pick what you know works and it's cheap because you know it'll cost her pennies if she has to pay for it out of pocket. What, drugs or food? You want to be responsible for that? And you don't know she's on this because she didn't remember. See? So that's the issue with these sorts of things. All right. Okay, Zoomers, any questions from cyberspace? No? All right. Then let's go to pharmacokinetics. Okay, gang, does the slides move on Zoom? They do? Okay, good. All right. Okay, so with pharmacokinetics, you're asking the question, what does your body do to the drug? What does your body do to the drug? So you have a dose that you administer. First thing is that drug is absorbed. That drug is absorbed. From the absorption, you get some sort of concentration in the circulation. Now, there's a term that is used for the percentage of the drug that ends up in the systemic circulation. That term is bioavailability. Bioavailability. This is reported usually as a percentage. So here in our table, we have oral availability, and it's given this number, capital F. Bioavailability is abbreviated capital F. Capital F. If you give a drug intravenously, by definition, its bioavailability is 100%. If you give a drug intravenously, by definition, its bioavailability is 100%. Because how do you define bioavailability? Drug administered, drug in the circulation. Well, with IV, you're putting it straight into circulation. That's why it's by definition 100%. Now, if you have your notes, please turn with me to page 6. And you'll see the different modes of administration. Let's talk about these modes of administration for a bit. First, let's consider drugs that are administered orally. The vast majority of drugs are administered orally. Can anybody guess why? Say that again, Jeff.
Is it the easiest?
It's the easiest. Exactly right. It's the easiest and it's the hardest to design. Yeah, it's convenient. It's convenient. That's why most drugs are administered orally. Now, when a drug is administered orally, I need more colors. First place it goes is, of course, in the oral cavity. And you get virtually no absorption in the oral cavity if the drug is administered orally. That's due to the preparation. It's not going to allow you to absorb anything orally. Now, there are drugs that can be taken underneath the tongue, and you see here sublingual. These preparations are quick melt preparations. They're very difficult to make, very difficult to design. So you put them under the tongue and it dissolves into a powder, and under the tongue, what's your blood supply like under the tongue? All right, your homework is to look in the mirror, pick up your tongue, and look underneath your tongue. You're going to see it's bright red. Why is it bright red? Lots of blood. So absorption under the tongue is very efficient. Very efficient. Also, you have some drugs that are administered in a buccal strip. A buccal strip. With that, it's usually a dissolving piece of paper. The drug is impregnated in the paper and you cheek it. It dissolves, it releases the drug, and the gum and the cheek absorb the drug. That is also very efficient as well. There aren't many preparations that do this, but there are a few. One in particular, Suboxone. Suboxone is a preparation that contains buprenorphine. Buprenorphine is used for opiate abuse disorder. And then in that is also naloxone, which is an opiate receptor antagonist. So if you take it and squeeze it and try to get the drug out, then the naloxone comes out and the buprenorphine doesn't. So if you try to abuse the drug that way, you not only don't get any high, it blocks those receptors and you feel like crud. So it is an abuse, it's a tamper-proof type of preparation. Very ingenious. That's called Suboxone. Also, there is a antipsychotic called amisulpride, which is not available. Well, it is available now in this country, but not for schizophrenia. It's used off-label for schizophrenia. It's available in Europe. And it comes as a strip, buccal strip that you cheek. And it gets absorbed that way. All right. Now, if Sonoro prep, virtually no absorption here. Then it goes down the esophagus to the stomach. The esophagus is not really an absorptive structure. You don't really get any absorption in the esophagus and the stomach. If your drug is a weak acid, you'll get absorption in the stomach. If it's not a weak acid, you'll get very little absorption in the stomach. So aspirin is an anti-seizure medicine called phenytoin. Those get absorbed in the stomach. Ethanol gets absorbed in the stomach. And there's a few others. Most drugs don't get absorbed in the stomach. From there, it goes to the small intestine. SI does not mean Sports Illustrated. Small intestine, most drugs are absorbed in the small intestine. Very few drugs are absorbed in the colon. Very few. If drugs are dissolved in bile salts, they may be absorbed then in the lower small intestine and early colon. Those drugs are not that common. So colon, that's going to be minority. This will be your big gun for your drugs. Now, if you absorb a drug orally in the small intestine, what's its first stop in the circulation? I know I'm taxing your A and P here, but that's okay. A little review never hurt anybody.
I don't understand what the fuck.
When you absorb stuff, the blood that drains the small intestine goes where? What's its first stop? Liver. Turns out the liver is the biggest metabolizer of drugs. That's going to be important because some drugs, when you absorb them, they go to the liver and they get broken down very quickly. That's called the first pass effect. The first pass effect. Let me give you an example. Morphine. Morphine can be made into a pill. Why is it never given as a pill? It's subject to an extensive first pass effect. That's why morphine is always given parenterally. When you give a drug parenterally, it means you give it with a needle. You give it with a needle. So intramuscular, intravenous, or subcutaneous, those are all parenteral modes of administration. So if we look here, we see subcutaneous, put a little check mark by that. Intravenous, put a little check mark by that. And then, oh my stars, I don't see intramuscular. Did I leave that off? Shame on me. Well, I should have intramuscular. That would be the third mode of parenteral administration. I can't believe I did that. Oh, well. Let me ask you a little question here. What does aging do to absorption? What happens as you age? What happens to your GI tract as you age? Motility goes down. Motility goes down. So food now spends a longer time in the GI tract. So as your absorptive capacity goes down, so does motility. So actually absorption overall actually stays about the same. But if you have a drug that tends to cause some decrease in motility of the GI tract, like anticholinergics, they're going to make the constipation much worse. So what might not be a problem in a younger person will cause a lot of trouble in an older person. Just something to consider. So absorption in healthy elderly is really not changed all that much. Then we have distribution. Distribution. So pharmacokinetics involves absorption, distribution, metabolism, and elimination. Distribution is number 2. Please turn to page 5 in your notes. If a drug is water soluble, here's essentially the compartments where a drug might partition. So total body water will be 0.6 liters per kilogram body weight. That's assuming someone is not severely dehydrated. Extracellular water is going to be 0.2 liters per kilogram body weight. And then your blood plasma, that will be the site where most of your water-soluble molecules will go. Then you have fat and bone. So you can essentially take the water pieces, add all those up. That's going to be your zone of distribution for water-soluble drugs. Now, what happens if your drug is not water-soluble? What if it's lipid-soluble? Then it's going to tend to partition to fat tissues. Now, let me ask you, how is distribution going to be affected as you get older? Well, what happens to lean body mass as you get older? Goes down. Distribution is hugely affected by aging. Hugely affected by aging. Many of you will deal with an aging population in your practices. Why? Because older people get sick more often. And this is something to keep in mind. If you give an older person a lipid-soluble drug, it's going to tend to stay in their body for longer, and it's going to tend to be sequestered in fatty tissue. Also, consider this too for those of you in nutrition, fat-soluble vitamins. What will happen to fat-soluble vitamins? They'll tend to partition to the fatty layers. And it'll be more difficult for them to get normal blood levels with usual doses of fat-soluble vitamins. That's why many aged people who are overweight are actually vitamin D deficient. And did you guys hear or see about the study that Case Western did? So in Britain, there is a database where they take patients and they draw their blood and they get all these variables and they put them in a database. And then they use that database for epidemiological studies. So 2 Case Western people looked at that and they said, okay, if you're vitamin D deficient, which in England most people are, because the sun never shines there during the winter, what's your chances of having more severe cases of COVID-19? The correlation was scary. Scary. If you were vitamin D deficient, you had a 14 times greater chance of being hospitalized with COVID-19. You had a 7 times greater chance of dying from COVID-19. That's why the British government has started to distribute vitamin D to all of its citizens. Now, granted, they're only giving them 400 units, which is pathetic, but that's how much they believe essentially in the data about vitamin D and COVID-19. The data is really starting to become overwhelming. In fact, that was a little aside. All right, bone. Some things will actually end up in bone. And this is something to consider with patients on drugs like lithium or something like that. The elimination involves first metabolization by the liver. So there are 2 sites where the drug will usually be metabolized. Site number 1 is kind of number 8 in the batting order. Not a very big hitter. Somebody who hits probably 202, something like that. That'd be the small intestine. So some of your absorbed drugs, if they're taken orally, they'll undergo some metabolism by the small intestine. Parenterally administered drugs will not experience the small intestine very much. So this will be really, really minor. The big heavy hitter, the one hitting number 4, in the batting order, who hits 454 and has 60 home runs and 150 runs batted in, that's the liver. That's the liver. That's the one with the big stick when it comes to drug metabolism. Evan, that was for your benefit, the big stick. Oh, gee, I actually got a smile out of Evan. Good to see. Now, this drug metabolism, some people think drug metabolism is to detoxify the drug. No, 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 no. Write this down. Write this down. Drug metabolism does not equal detoxification. Sometimes drug metabolism will detoxify it. Sometimes drug metabolism makes the drug worse. What is drug metabolism trying to do? It's trying to make the drug more water soluble. Write that down. It's trying to make the drug more water soluble. By making it more water soluble, it makes it easier for your body to eliminate the drug. Gotcha? Gotcha. Benzopyrenes. Think of benzopyrenes. Benzopyrenes are found in burnt breads, burnt meat, cigarette smoke, burning motor oil, things like that. Your metabolism of benzopyrenes actually activates them, makes them worse. So drug metabolism does not equal drug toxification. You're trying to make the drug more polar, trying to make the drug more water soluble. That's what drug metabolism is for. Then you get a concentration of the drug at the site of action, wherever that is, wherever those receptors are. Then you get a pharmacologic effect. You get a clinical response from that effect, and you get efficacy, and you may also get some side effects depending upon the drug and what have you. So this piece up here, that is pharmacokinetics. This piece down here, that's pharmacodynamics, because now the drug is dealing with the receptor and is eliciting its physiologic response. And these factors here are going to largely determine the dose that you will give the patient. So the goal of therapy is to achieve the benefit with as few side effects as possible. Therefore, the drug will be given within a certain window. If you go above that window, there's usually a caution, and then there's usually a dose above which you just don't go, except under very, very exceptional circumstances, and usually without the endorsement of the manufacturer. So the dose is based on clinical trials. Clinical trials. Once you complete your pre-clinical trials successfully, you apply to the FDA for an investigational new drug application, an IND. The IND allows you to conduct clinical trials in human patients. In human patients. You get your initial drug concentration from the animal studies. That drug concentration virtually always has to be adjusted for human patients. Once you establish a safe and effective dose in your phase 1 studies and phase 2 studies, if you successfully complete phase 3 studies, you then apply for the new drug application. That permits marketing of the new drug for a certain condition at a certain dose using, this is important, a certain preparation of the drug. Because what the FDA licenses is that preparation of the drug. And you have to specify very carefully how it's manufactured and so on and so forth. That's why licensing generics can be such a pain in the wazoo. Gotcha. The generic is the drug that's in it. The trade name is the preparation of that particular drug. So for example, let's see, think. Okay, Tylenol. Tylenol is a certain preparation of acetaminophen. That particular preparation allows you to take usually about 1,000 milligrams every 6 hours during the day, not to exceed 4 grams during the day, and as an analgesic for pain. Generics essentially can have preparations that are also effective. They may mimic the brand maker of Tylenol. I think, who made Tylenol originally? It wasn't Bayer. It was, well, whoever it was, I don't remember. But whoever initially made Tylenol or some of your allergy drugs that you guys take, some of those are specific preparations. So Zyrtec now is in a generic preparation, and cetirizine, which is the drug in Zyrtec, that's now available in the preparation, essentially allows you the same efficacy, supposedly, as licensed brand name Zyrtec. You just pay a lot more for the brand name Zyrtec. So that's essentially what the NDA specifies, the preparation of that drug, and the generic name is the active component of that drug. Clearance is a term given to specify how the drug is eliminated from the body In equations, CL refers to clearance. Some drugs have multiple means of clearance. Some drugs have very few means of clearance. So the main means of clearance is by the kidney. But some drugs can be released in sweat. For example, there's a tuberculosis drug called rifampin. Rifampin, if you wear contact lenses, it will stain your contact lenses orange because it's secreted in tears. If you sweat, it'll stain your clothes orange. And yes, it will turn your pee orange too. So that's a drug that is cleared by multiple pathways. You have a skin, you have a tear, you have a renal sort of excretion of rifampin. Some drugs are excreted in bile salts and then are eliminated through the digestive tract. Some drugs are only excreted one way. Some drugs will cause a metallic taste in the mouth because they're excreted in saliva. So metronidazole, which is a drug, an antibiotic that's used to treat anaerobic infections, people say, man, my taste is off. It's awful. Ugh, everything tastes like iron because it's secreted into the saliva and then you swallow it. That's an example of a drug that also has multiple modes of clearance. Now, when you calculate clearance, you have to say CL renal plus CL skin plus CL GI plus CL whatever. It has to be total clearance. For some drugs, it's just one mode, not an issue. So we're going to look at an anticoagulant in this course called the Bigatran. The Bigatran is secreted, is cleared by the kidney, and that's it. It's not cleared any other way. All these other modes, you can ignore them because they're so low, it's effectively zero. Others, you have to take into account their other modes of clearance, and your tables in your page 8 give you essentially, oh crumbs, where are those tables? Here they are. There is a table that says clearance. Page 10. And you'll notice that clearance is in liters per hour per kilogram body weight. Liters per hour per kilogram body weight. And you'll notice you also have percent urinary excretion. Just look at these with me for a while. Some of them are not cleared by the kidney very much. So if we look at cyclosporin or diazepam or fluoxetine or HEC, amphotericin or even aspirin, not really cleared very much by the urine. So that's something to consider as well. Now, what if you have a patient who has decreased renal function? What if they have some sort of kidney disease and they're mainly cleared renally? You're going to have to adjust the drug for their renal clearance because the drug's going to accumulate in their body. That's something to consider. Volume of distribution. That refers to the space that the drug is going to occupy in the body. And that table we looked at earlier gives you essentially the places that the drug can occupy. You calculate that, and that tells you the volume where the drug will essentially go once it's absorbed. That is different from person to person. The V sub D, the V sub D. And the clearance, as we said, will be total modes of clearance. So the rate of elimination divided by the concentration of the drug in the plasma, and this will apply to both the mode of elimination by the liver, mode of elimination by the kidney, mode of elimination by whatever. Some drugs are volatile, and you'll actually get rid of them by exhalation. Some anesthetics are that way. Most drugs, the more drug you have in your body, the faster you get rid of it. So it's drug concentration dependent. Clearance goes faster with more drug in the body. That's called capacity limited clearance. Capacity limited clearance. So with this sort of, oh, I need to erase. With capacity limited clearance, you'll have essentially a sort of relationship such that when the drug gets to its highest concentration, you give a bolus of the drug. Elimination is very fast, and then it slows down as it gets less concentrated in the body. So essentially, you'll have a slope that is going to be logarithmic. It'll be logarithmic. Like that. Flow limited clearance. Flow limited clearance refers usually to drugs that are cleared by the liver, usually the liver. But in this case, its clearance will be affected by the tendency of the blood to flush through that organ. That organ almost always being the liver. And here are some examples of a few flow-limited drugs. So ones for our purposes that'll be important will be, of course, morphine and pyridine, and then verapamil and propranolol, labetalol. That's a tuberculosis drug. Isoniazid, imipramine and desipramine are both tricyclic antidepressants, as is amitriptyline. Aprendolol is a beta blocker, but it's not used anymore in human medicine. Lidocaine, that's what you get at the dentist's office to numb you up. Lidocaine is probably the most widely used topical anesthetic in general. It's very safe. Is mepivacaine used more than lidocaine from your experience, Greg, or you don't remember? Lidocaine is used the most, probably. One, is cheap, and it lasts a while. Two, mepivacaine is very short. I think if you want a short procedure, maybe use mepivacaine, but usually it's lidocaine. Greg is a future dentist, that's why I asked him. All right, so yeah, these are the ones that are examples of drugs that are flow limited. And you don't need to remember these. I will tell you if a drug is flow limited. Okay, next time, Wednesday, we will finish pharmacokinetics. We'll take a look how you use this to calculate proper dose. And then from there, we'll move on to drug biotransformation. Okay, gang, have a good day, stay well, and I hopefully we'll see you soon. Ciao.